Welcome to the podcast of the TriHealth Medical Minute. Mike McConnell, your host, and my guest this time out is a cardiologist, Dr. Sateesh Kesari, with the TriHealth Heart Institute. And first of all, Dr. Kesari, it's good to have you here. How are you doing, sir?
Mike, thanks for having me on board. I'm doing well, thank you.
All right, you're a cardiologist, and we're going to talk about something that first. How does cardiology differ from cardiac surgery, as an example?
So my specialty within the field of cardiology is what we refer to as advanced heart failure and transplant cardiology. So my specialty focuses on patients on a wide variety of issues related to the heart pumping action, which includes advanced heart failure, end-stage heart failure patients, patients with pulmonary hypertension, inherited cardiomyopathies, and I spend a lot of my time working on patients for cardiac transplant or mechanical pumps for the heart, which we refer to as left ventricular assist devices. We differ with regard to cardiac surgery, but we partner very strongly with them. Our goal is to evaluate patients for years before these kind of big surgeries, and part of our heart recovery program that we developed at TriHealth, we try to be we try to optimize patients to never need these kind of end-stage therapies,
Mm-hmm.
part of the recovery program. And then when they do need it, at least identify those patients that have irreversible cardiomyopathy and help them get into see our CT surgeon who specialize in these mechanical pumps. And then post-implant, they predominantly follow with advanced heart failure cardiologists to manage that pump and issues related to that so they're optimized and they do well for years afterwards.
All right, I want to talk about LVAD here, and it's an acronym, just LVAD, pronounced LVAD. Explain first what does LVAD stand for, and then just the overview of what it is.
So the what it stands for is left ventricular assist device, and what it does is the left ventricle, one of the four chambers of the heart, is the predominant ventricle that pumps blood to the rest of the body. And when patients fail, they fail predominantly on their left ventricle, and the device is a mechanical pump that's placed through multiple different modalities, but usually through a median sternotomy with an open chest approach, and we place the VAD, the left ventricular assist device, in the left ventricular apex. It through a magnetically levitated rotor, it draws blood out of the left ventricle, redirects that blood through a graft into the ascending aorta, thereby perfusing the rest of the body, allowing patients to live longer, feel better, and providing end organ perfusion. There are other minimally invasive approaches to this, include a lateral thoracotomy, but that is the general
Yeah.
gist of what the device is.
So it's implanted then, correct?
It is implanted and permanently placed in multiple different scenarios where it could be destination, and that's what you get for life, and maybe reimplanted in the future. Other scenarios are bridge to transplant. Those designations have really gone away since they have similar mortality, at least 2-year mortality to transplant.
All right, then. So typically, who is a candidate for this LVAD, which sounds interesting?
So patients that are candidates for they're a wide variety, but they're end stage heart failure patients. So these are patients that we can identify, and I think will be great for your audience is if you just look on the internet for the I Need Help flyer that is kind of supported by the Heart Failure Society of America and American Heart Association. It's an acronym that identifies patients that would be at high risk of doing poorly over the next year, and these include patients on a drip like an inotrope or a medication which we refer to as milrinone or dobutamine that they require just to keep their heart pumping well enough to perfuse the rest of the body. Also, patients that are like dyspneic or short of breath, even with a little bit of effort. Patients who have poor perfusion to end organs like the kidneys because of their heart failure. Generally, these patients have an ejection fraction or the squeeze of their heart is less than 25%.
Hmm.
Other patients could be patients that are getting heart shocks or frequent hospitalizations, and more commonly, patients that you notice that we cannot reduce their volume excess from edema, or they have low blood pressure, but a really bad prognostic one is when we have you on good medications, but over time, because of your heart failure, we have to de-escalate that therapy, and that's a pretty poor prognostic sign that you're coming into that window of end stage where we need to start considering transplant or a mechanical pump.
Yeah. Now, how is it powered? It's battery powered, I would assume. You're not going to be plugged into something. So how's that work?
So the pump has a drive line that extends from the pump that's implanted in the left ventricular apex in the chest, and it comes out through the abdomen. That drive line is hooked up to batteries that are, you have variables. It's very convenient and very easy on patients. Those batteries power you for about 17 hours with one set, but you get enough sets to last you for days. And then in addition to that, there's a wall unit that you can just plug in indefinitely.
Wow. So the batteries are these aren't your typical D cells, I'm guessing, huh?
No, they're high grade batteries that can last for a while, and
Sure.
a lot of redundancy to it. There's some redundancy even in the controller that we use to manage it. There's some within the machine itself, but the companies have done a great job in optimizing the batteries, and they're doing better and better,
Yeah.
and work on even wirelessly kind of charging these batteries in the future.
So how long might somebody have this LVAD as part of them? The prognosis. What would it be for somebody with an LVAD?
I think what's important in that regard is to relate to what the prognosis is without an LVAD. And I think we've had clinical trials that have demonstrated the 1 and 2 year survival is pretty dismal. Some trials say about 24% survival in 1 year and 8% at 2 years on chronic inotropic therapy, but generally you can put it at 17% are alive at 1 year, which is pretty dismal. With our newest LVAD, we have a 2 year survival that rivals transplant at 83%. So it's a marked difference in survival.
Sure. So how long has TriHealth had the LVAD? And how long was your training, I guess, to be certified, so to speak, on the LVAD program?
So I joined TriHealth about a year and a half ago to help them build a program along with my colleagues with CT surgery, critical care medicine, and the cardiologists who have been extremely supportive of this program. That build has involved an intense hiring of staffing related to the program, and with a lot of administrative support as part of the general heart hospital build here. And we've added on significant staff, which includes advanced heart failure MPs, advanced heart failure pharmacists, two VAD coordinators, VAD social worker, VAD dietitians, and we've gotten to the point that we've gone through a review with national organizations. Our review was with DNB. They reviewed our program in December and cleared us to be the implanting center for left ventricular assist device. They gave us actually a glowing review of that. In addition to that, just as of yesterday, we've been listed on the Center for Medicare and Medicaid Services as an implanting center for left ventricular assist devices.
Well, congratulations on all of that.
Thank you.
Yeah. So the comprehensive care center there at Bethesda North has been expanding dramatically as far as the heart program is concerned. Is that fair to say?
Immensely. I think my role as the director for the advanced heart failure program for the network here, and also part of the left ventricular assist device program and the pulmonary hypertension program is to have programs in place that manages all these patients. So we have 20,000 identified heart failure patients within the attributable lives to TriHealth. For that program, there's some that need these specialty programs like the left ventricular assist device program.
Mm-hmm.
But what we are building is something that's more comprehensive that kind of identifies all the heart failure patients within the wide spectrum of heart failure patients that we have within our network. And to that effect, we're building out a very streamlined communication stream and ways of identifying heart failure patients throughout our network. We have other programs that we've built surrounding that, which includes our CardioMEMS program, and recently really got our virtual heart failure clinic up on board so we can be really remotely managing patients through devices and technologies. And then one program that's really done really well for these patients is our heart recovery program, which we put them on a very scheduled optimization of medications to hopefully and kind of reverse the heart failure.
Right.
And we've had pretty great success with that, with ultimately avoiding these more advanced therapies, but at the same time, identifying patients who are not improving and do require them.
Well, it's good to know that this is there for people if you need it, but avoiding it would be the smartest thing to do. So just run down some of the key things you should do to maintain a healthy heart.
Well, I tell you, once first of all, identifying like symptoms to know that you might be going down, and some ways, getting in touch with your general cardiologist to have an overall, or your primary care doctor, or an overall review of your risk factors. And if you are at high risk, like high blood pressure, diabetes, smoking, look at identifying those risk factors with your primary doctor or your primary cardiologist. But once you've already developed heart failure, then the network that we build to identify these patients, put them into different recovery programs, follow through a virtual clinic, implant devices in the body that actually can look inside and tell you about volume status.
Mm-hmm.
These all over time help recover the heart, as well as help prevent needing these more advanced therapies. And I think we've had pretty great success, and we have a dual role, one that is trying to prevent needing these transplant or left ventricular assist devices, which is the big focus, but then also having these programs available when patients are too far along and they will not be able to, they have irreversible disease that will not be able to fix.
Okay. Well, I appreciate your help and your expertise. My guest this time out was Dr. Sateesh Kesari, a cardiologist with the TriHealth Heart Institute. And you can find more information about LVADs and TriHealth physicians and more by visiting trihealth.com/heart. And we'll thank you for listening to the TriHealth podcast at 700WLW.com. Dr. Kesari, thanks so much for your time, your expertise. It's a pleasure, and I think we should do it again down the road, sir.
Mike, it was great talking to you. Thank you for your time.